continue and not leave the meeting. So like Cindy said, my name's Caitlin Coogan-Sherman. I'm going to talk about pediatric burn injury today. I'm a nurse practitioner with the general surgery service. Started out at Children's in the ICU, then was in the ER while I went back to school, and then started with general surgery burn trauma, and I've been there for almost 5 years. So stop me if you have any questions as we go along. So key components of burn assessment. So I gotta move this screen out of the way so I can see. The mechanism of injury. So what did the child touch? What was spilled on them? How did the burn happen, basically? Then the intensity and duration, and we'll talk a little bit more about that, but those things are important because when you first see the burn in the emergency department, it may not be clear what level it is at first. And so getting a good history about this part, or encouraging whoever you're seeing the patient with, the doc or resident or whoever, to get a good history about how long the thing was on the kid, what the parents did after they realized the kid had a burn. And then time is very important, not just for our bigger burns that will end up in the ICU, but even for the smaller ones, so that we know how far this thing has progressed, how much farther we have to go. Then obviously location is important. The emergency department only consults us for certain types of locations. If it's smaller than 5% on maybe the chest or abdomen and doesn't cross a joint, they may not call us for that. But if it's on a hand, if it crosses a big joint, if it's on a face, we definitely want them to call us. So location is important. Also, getting different services involved depending on the mechanism and location are important. TBSA, which is total body surface area. We'll talk a little bit more about that. And then depth. And depth is kind of an evolving assessment because burns evolve over the first few days, and sometimes bigger burns evolve even past that, depending on if the kid gets sick. Hold on. So guidelines for emergency department burn management. So this means that the team in the emergency department will handle these burns under 5% by themselves without consulting our service. So, and our service means after hours, you would get a resident who may have never seen a pediatric burn before, which is, the least amount of expertise you'll get, versus you could, between 8 to 5 on a weekday, you could get a nurse practitioner who has been treating pediatric burns for 10 years. So it's important for you guys as nursing, as part of the Swiss cheese model, all of those things, to understand who is the provider who's seeing this kid, and do they know even anything more than I do, or are they like super duper expert? Because the less they know, the more questions, clarifying questions you want to ask to make sure this family gets the care that they need. So that's important to understand too. So if there's any involvement of the airway or the eyes, now airway is interesting because, like, if you have a scald burn, you wouldn't necessarily think there is any airway involvement, right? The kid is not gonna spill water on themselves and also drink boiling water to give themselves an airway injury. So, but if you're talking about smoke, then that you would want to think about an airway injury. Genitalia, we always like to see, we treat it a little bit differently. And obviously, especially the younger kids in a diaper, like we would treat that differently than the same type of burn, the same TBSA on a different part of the body, because it's going to be wrapped in a diaper and potentially a soiled diaper for different, periods of time. The palmar crease on the hand, so that's this big line that goes across. If you have little spots here or there on the palm, or you have like a couple of finger pads that don't cross any joints, we're not too concerned about that. We'll see them in clinic. But if you have, you know, the entire hand, we'll see a couple of pictures covered. We definitely want to see that kid, and we want to have occupational therapy, probably see them in the ER, but definitely get them on board for clinic. If there's any concern for non-accidental trauma, and you know, this is also something that comes with time and assessment of these kids, whether the injury fits the story, and you will, hopefully this will give you some insight into that. But you know, our burn clinic is full of babies between the age of 12 months to 3 years who pull hot water on themselves. So if it's your first time seeing a burn like that, you might think, oh my gosh, somebody threw water on this poor baby. This is an NAT. The more you see, which for us is, you know, Monday, Wednesday, Friday, all day long, every day, we see about 5 of those kids a day between those ages who has pulled somebody else's tea or coffee or something on themselves. So you get very used to it, and you then you can help guide the provider, especially if they haven't seen very many burns, about like, you know what, actually this story is what we see all day long every day. This doesn't seem like it's fishy. But you always have social work in the ER to do a screen, even if you don't want to call CPS, or even if you don't want to get children or adolescent protection involved, which is a little bit of a step up. You can always ask for a social work screen, and I'm pretty sure those can be initiated by nursing as well. If it's caused by a treadmill, those burns are really, really deep for the most part. So we want to see those burns or get a consult for those burns. And I'll also include in here vacuum cleaner belts. Basically the same idea as a treadmill, like they get a, you know, continuous shearing on the same spot. And kids don't react as fast as adults, so they often hold their hand there or get stuck and then have that continuous shearing. And often those burns are very, very deep. So if a surgical consult is requested, you can prepare ahead of time, which is greatly appreciated by everybody. And especially if you, you know, we always appreciate you preparing, although we often bring like a bag of stuff that we want to use. But especially if it's after hours and you're having a resident or somebody who doesn't see a lot of these burns all day long, every week, in and out, if you prepare the things that you think will be needed, oftentimes that can help guide their care. So the more you get comfortable with it, the better you can prepare for us coming down to do the debridement. And then you know what to instruct the family, which is always comforting if they get the same story from everybody. You can prepare the materials, and you often might find that you know the materials better than the some of the surgical residents. They get a similar training, but you know, once you've been around for a while, you will have seen more than most of the residents. So you can prepare the things that you know that we have, and they might not even know that that's a product that we have, or that that's what we generally like to treat this type of burn with. So you can kind of guide them just in your preparation, which is wonderful. So wound cleanser and gauze are basically what we use for debridements. Just do kind of like a traction debridement. Then add pain control. So this is a huge nursing thing. I mean, residents and providers often will come down and say, okay, I'm ready to do this. This is my 10-minute window. Let's do it right now. And it's really up to you guys to make sure, A, that these kids are getting pain control when they show up to the emergency department, or if you're in the ICU, that you're calling the team to plan when your sedation is going to be, or if you're on the floor and you know you have to give oxy 45 minutes before we do a burn debridement, to make sure you're really advocating for that patient to get the pain management that you think they need for the size of burn, for the anxiety level, all of those things ahead of time so that you can take the best care of your patient as you can. Because if you don't want somebody, a provider, rolling up and ready to do the burn dressing, and then you start advocating for pain meds. So something you should think about beforehand, but you also can always say, you know what, we got to stop this. The kid does not have their pain adequately controlled. Give me whatever amount of time we need to get this kid in a place where we're not gonna where we're not gonna scar them, or not scar in a burn way, but cause any more trauma than the kid has already had. By the time some of these bigger burns or kids have come to successive clinic visits and had these things done, they are pretty traumatized. So if you can help curb some of that trauma in their first encounter or in their subsequent encounters on the floor in the ICU, that is huge for these families. I mean, some of these kids, it takes a long time for them to recover, not just from the burn, but from the trauma of having continuous dressing changes. And our team is continuously, and the trauma team downstairs is continuously working to figure out how we can better treat these kids' pain and do as much as we can in the OR or under ketamine sedation, or we're working on trying to get things like nitrous and stuff to try to make these painful episodes for these kids less and less, because we can really cause PTSD, not just from the burn itself and when it initially happened, but all of these subsequent treatments. So that's a huge role you guys can play. Burns bigger than 15% TBSA, and we'll talk about how to measure that, or at least guesstimate, are done in the ICU or the OR. So these kids should be getting to the ICU, I think within an hour is our goal, so that they can start on fluid resuscitation and get sedation to get their dressings, their debridement and their dressings on. Oh, sorry, let me go back to the slide. So I say all of that to say the biggest pain that these kids experience is when the burn is uncovered. So if somebody comes down and says, we got to get this dressing on, and the burn is mostly debrided, and you have everything set up, and the kid is screaming bloody murder even before you start anything because they're in pain, what causes pain in a burn is the air hitting it. Just like I'm sure everybody has burned themselves on the oven, burned themselves doing whatever, curling iron. Once it's covered and has some aquaphor or dressing on top of it, the pain is decreased significantly. So you do have to weigh that with, like, are we waiting here for ketamine sedation and it's going to be 4 or 5 hours until we can get this kid debrided? Do we want to put on some kind of temporary dressing in the meantime? Or can we do this thing quickly, and then once the kid is wrapped up, they're, feel a ton better? So that's also, part of the discussion. And we want to reduce the pain, whether it's getting a dressing done. If we think we can do it super quickly and get them wrapped up, and it's not a huge amount of debridement, or we know they're going to go to the OR the next day, getting them wrapped up in a timely fashion so that air isn't hitting the open wound bed. So this is one of the apps our team uses, and we ask our residents to download, and it's called NSW Trauma. It is a free app. I think it's out of Australia. We're working on producing one ourselves, but it helps calculate TBSA based on weight and age. And so you just color in, I thought we had a picture of it, but you just color in where the burn is on the patient, and it spits out a number for you. So we often do 2 different versions of TBSA so that we can kind of make sure they match. And we ask our residents to do the same, and our ER providers. So we'll do an NSW picture where we color in the area of the burn, and it's based on the kid's age and weight, so that, because a baby's head is 1/3 of their body, and adults is 1/8. So everything changes as you grow in terms of proportion. So the other method we use is 1% TBSA is palm and fingers. So we're not talking about this part. We're talking about the entire palm, and it's not your palm, it's the kid's palm. So if you have a kid that's burned on the chest, you can easily put their hand over the areas. And oftentimes people will say, oh, we have a kid with a 10% burn. And we come down and it's, you know, one small area on their cheek and 3 hands on their chest. And that's an easy way to say, like, okay, no, this is not quite 10%. This is more like 3.5%. But getting a measurement of the kid's hand, and you don't have to take out a tape measure. You don't have to do any of that. You just kind of look at it, or you can actually physically take the kid's hand and kind of place it near there. And that's a really, really good estimate. And we get very, very close. And oftentimes the palm and the NSW are within a percentage or two from each other. The importance of estimating burn size are manifold, but a greater than 25% TBSA is a trauma activation. So these kids need to go to the code bay. They need to have the entire team, everybody mobilized. 40% needs a burn attending. And so that's like the difference between a trauma and a trauma stat attending. Because oftentimes these kids will go immediately to the OR or immediately to the PICU, and may need significant fluid resuscitation and lots of resources. Another thing about percentage, over 15 goes to the ICU, and over 15 we generally put in an NG, if not in the emergency department, as soon as we get to the ICU, for nutrition, which is hugely important. These kids healing their burns. So we'll talk about different types of burns, depths of burns. So superficial burn is your sunburn. Erythema or redness, and it blanches. So when you press on the skin, it's like peach and goes back to pink or red. It is painful. Any of you have had a sunburn, and they will heal within 1 week, whether you put moisture on it, whether you don't. These kids can follow up with their primary care person or not. Oftentimes you will have combination burns. So you may have like a scald burn that has a big blister in the middle that's 2% of your TBSA, and then a surrounding area that's 5 palms worth of red erythematous, but blanching and not blistering. So what we call the TBSA does not include superficial. We will moisturize and often treat that area conservatively. And sometimes if we treat with a product and we're going to wrap the kid up and not bring them back for 5 to 7 days, put them in a long acting dressing, then we will also treat the superficial areas with whatever treatment we're doing. But those areas are not included in the TBSA because that skin has not blistered. They're not at risk for fluid losses, for massive amounts of nutrition needed to heal that burn. So the difference between saying a kid has a 2% or a 7%, if you're including that superficial burn, you would treat them differently. So we don't include superficial burn in their TBSA when we're talking about it. We do comment on it though, to make sure, we have the full picture. Superficial partial thickness, if you can see on this baby, is this shiny pink where they've had to the chest and shoulder and part of the head. It's pink, it still blanches. So when you press it in, it turns white and comes back to their regular pigment or red. Once something blisters, it's automatically at least a superficial partial thickness. Once it blisters, it's gone past superficial. So there used to be 1st degree, 2nd degree, 3rd degree. We don't talk like that anymore. Superficial basically is a sunburn, and then superficial partial thickness is, there's 2 types of partial thickness, superficial and deep. And those are basically the old way we used to talk about it, were the old 2nd degree burns. These have intense pain because they're right at the level of the nerve in the skin where a lot of the nerve endings are. So there are a lot of pain there. These heal within 1 to 3 weeks, although I'll tell you on kids, the younger the kid is, the better they heal. The younger the kid is, and then the area. So faces are super duper vascular, and so vascular areas heal faster. So this face, I would imagine, would heal in like 4 to 5 days. Whereas the chest and shoulder may take a week to 10 days. These areas, basically, we tell parents if the burn has healed within 10 days, it's very unlikely to scar. But a lot of things affect scarring. If this kid got a terrible URI in the middle of healing and it took a little bit longer, and it affected their nutrition and they had fevers and all kinds of those things, which often happens in our infants and toddlers, is getting some kind of illness in the midst of a burn, or having an illness and then getting a burn, because these kids have 20 URIs in the first 2 years of life, so they're basically always sick. So those things can slow down burn healing, and so the slower the healing goes, the more likely you are to have a scar. Depth, but also length of healing. Deep partial thickness, this is where you can see it's a little bit less painful, but still very painful. And the areas that are most painful are those edges. So you see the middle there is still moist. Partial thickness burns are always have a moist wound bed. I should say most of the time have a moist wound bed, but you see that middle area is really light pink. And that's actually deeper, and you can see the edges are red. You can see where the blood vessels kind of are, and so those are the less deep areas, and those areas will likely heal first. Deep partial thickness, sometimes, depending on the age of the kid and the vascular area, can heal within 2 weeks. But oftentimes what you'll see is like a big area of this burn around the edges has healed in 7 to 10 days. And then we're dealing with much smaller areas centrally that have not yet healed. So areas that haven't healed in 2 weeks, there's a likelihood of scarring, and there's a bunch of things that we do in the burn clinic and scar clinic to help with scarring. Silicone products, compression garments, we do laser treatments, we do all kinds of different surgeries. Sometimes we refer them to plastics for scar excision. So basically, we tell parents their first question is always, is this going to scar? We tell them we don't even know yet if this burn is done progressing. Oftentimes they progress over 72 hours and can become deeper and deeper. So that's why our initial treatment is very, very important. But also we tell them a lot of it has to do with genetics. Do you have people in your family who keloid or have bad scarring? Some of that we cannot control. We also, say the importance of high protein, high calorie diet while these kids are healing, so that they're able to heal faster and regenerate that skin, so that they can heal without scarring, because if they can heal within 10 days versus 14, there's less likelihood of a scar. We talk to parents about hydration and also keeping their kids away from anybody sick, or trying to keep them healthy, which is hard, and like a 1.5-year old baby who's picking up everything off the floor and eating it. It's hard to keep them not having URIs, but if you can avoid getting sick, if you can keep on a high protein, high calorie diet, if you can get it covered and treated in the right way early, and then some of it is just up to genetics, and how certain people's skin heals. Some people's skin heals very well, and some not as well. This is a full thickness burn. So as opposed to a moist burn, which is partial thickness, this is dry. You see in the middle, it looks like brown, leathery stuff, like it hasn't even been debrided yet. And that is what we call eschar. There's very little pain in the middle of these burns, although the edges often are not full thickness. The edges are often still partial thickness, so they will have pain there. But like this baby palm, if you pressed in the middle of it, that baby probably would not even cry. Some of these require skin grafting. Some of it depends on the size. Some of it depends on the age of the baby. Oftentimes in kids, we try to allow them a certain amount of time to heal primarily before we do any grafting, because oftentimes you can start out with a burn that is 3 or 4% size, and after treating it for a week can be more down to like a 1% size. So they'll heal from the outside in, and so often that'll help reduce the amount of size of graft that the kid needs. Because grafting, grafting shortens the amount of time of healing, but also the grafting, you have to take the graft from the kid. So you're giving them another area that has to heal, but also you might be giving them like a meshed pattern scar. So we kind of weigh all of those things and see what's best for the kid and what's best for the family, and how are they going to be able to follow up for all of these visits and do the things that they need to do to manage them conservatively, or do we need to get this taken care of because this kid is at risk for getting an infection? If they're getting sick, or if this kid has a large burn or is in the ICU, we go to grafting much earlier, because that dead eschar skin is what's going to cause these kids to have fevers and sepsis and all those things. So Cerner Capture is one of the other tools we use, and that's something that the residents and providers should have in the emergency department. And I only have this slide up to remind you guys to remind the provider who's taking care of the patient, especially if it's in the emergency department and they're not being seen by one of the burn NPs or by a resident who has it on their phone. And they're only being seen by the emergency department providers. These take a picture and send it directly into Cerner of the burn, and it helps us a huge, tremendous amount to have a picture. Just like they say, a picture is worth 1,000 words. Having a picture of this child's burn, where it is, how deep it is, and that helps us plan for clinic, helps us plan for their follow-up. Can this person be telemed? Can, all these different things that we can do with this kid. Can we prepare the family ahead of time? Make sure they're taking pain meds, because we know this is going to be painful or not as painful. So those pictures are hugely helpful. So if they get a prompt from you about that, oftentimes it's just the thing about memory. And if you're only seeing one burn kid a week, you may forget to take pictures in Cerner Capture. But if you're, they're just super helpful for us.
Caitlin.
Sorry?
Caitlin, if they take a photo, since it goes directly to the medical record, right?
It goes directly to the medical record. So this is an app that's through Cerner, and you pull the kid up by their MR, and it goes directly into the medical record. It's not saved on your phone. This is not a HIPAA issue.
Okay. We can use their face.
Yes, and you can use their face. You can put their whole entire body in it. You can put genitalia. These are pictures that are only in their chart, in their medical chart, and not saved on a phone. So that this was our, pictures are huge in a lot of areas of medicine. Burns are a big one. Dermatology, dental. People are, historically, since cell phones started, sending pictures back and forth to get help on consults, or send literally a visual of what they're dealing with. And all of those were not in compliance with HIPAA. This is totally HIPAA compliant. And so much better than taking a picture on your phone and sending it to someone, which is not HIPAA compliant. And those pictures can be, then uploaded to the cloud or done whatever, and not appropriate. So we, if a provider doesn't have Cerner Capture, we ask them not to take a picture. But these are hugely helpful for us before debridement, and then again after debridement. And they go directly in the medical chart, which is great. So these are some tips for the ER for when you're sending home minor to moderate burns, that you can remind the provider about. Pain medicine for for their follow-up appointment in burn clinic. So burn clinic, we are quite limited in terms of pain control. And so we ask providers often if they think dressing is going to be painful to give the family a prescription for oxycodone, or at least instruct them to give Motrin before, like 45 minutes before their clinic appointment or when they're leaving home, getting ready to come in, because that keeps our clinic flow going well, and the kid's not sitting there getting oxy and then waiting 45 minutes inside the clinic to have their dressing changed. We like to get these kids in and out as fast as possible to cut down on PTSD and all kinds of things. So getting pre-procedure medicine when they leave the ER to be prepared for burn clinic is wonderful. We often ask that they're debrided with gauze and wound cleanser, or even normal saline is fine. And then oftentimes we dress them with Meplex AG, sometimes bacitracin and Xeroform, especially for genitalia. We use that because it has to be changed often. The Meplex AG product is long acting, so a resident or a provider can put it on in the emergency department, and the kid can follow up in 3 to 5 days in burn clinic as long as it's debrided well. And then Curlex is just the white gauze that wraps around. We always ask the emergency department to send us an email to NP surgery. Our new email will be trauma burn, but NP surgery will be forwarded there. But that helps us make sure the kids follow up and make sure the kids have a clinic appointment. And then we have some burn videos that we give out. There are cards in the ER and in clinic. And Cindy has helped make a lot of those videos. I'm in a couple of them with my son. But burn videos for parents to learn how to do dressings at home. There's videos about being admitted in the hospital, and those are hugely helpful to families to have kind of a resource. These are some of our dressings that we talked about earlier. Xeroform is a Vaseline gauze that has some bismuth in it. So it is not bactericidal, but it is bacteriostatic. The bismuth makes it that way. So if you get a wound very clean and you put Xeroform on it, it can prevent some bacterial growth. And then we have Aquaphor, which hopefully everybody is familiar with. We use this a lot on faces because we don't do silver products on faces. So for faces, we either do Xeroform and wrap it if the kid is amenable to that. Faces get very, very gunky, and it's hard for parents to take care of them, because if you've ever tried to wash a 18-month-old's face who doesn't have a burn, they don't even like that. So washing the face of a kid with a burn that age is tremendously difficult. So oftentimes we will wrap faces with Xeroform and cling gauze if we can, because that helps prevent the buildup of the gunk, and then parents don't have to scrub and scrub. And so, that's always something to recommend if you're helping discharge a kid or helping wrap up a burn and one of the burn NPs isn't there, or somebody, who does a lot of burns. But otherwise, Aquaphor is great, and we just have them clean it once a day and put Aquaphor on. Sometimes we say twice a day, and then they come back to clinic and we do the real cleaning. Sulfamylon cream we use a lot on very deep burns or ears sometimes, because they're not very vascular. Silvadene we use everywhere on the body except for the face. It can cause hyperpigmentation on the face. There's some study that it can cause hyperpigmentation on the face. So we want to be really careful with kids. We're not dealing with like 50, 60, 70-year-olds who have a burn and may or may not care about a scar. I mean, these kids have their entire lives ahead of them. So we want to try and minimize any aesthetic issues that they may have in the future. And then Meplex AG is a great product we use all the time. It's silver impregnated foam, and that is also bacteriostatic, not bactericidal. Whereas Silvadene will penetrate deep into the wound and is like an antibiotic cream. The Meplex AG just sits on top. but it is great for superficial partial thickness burns, even deep partial thickness burns. And this is great for kids because it can stay in place for 5 to 7 days, and it sucks out some of the protein fluid that's produced by the burn, and so it keeps it drier, and then it doesn't get like grody sludge where bacteria can grow. It can stay, like I said, in place for 5 to 7 days. So instead of having a kid where you're changing their burn dressing every single day and causing pain, sometimes even if we know a burn is not going to heal right away or may need to eventually go to a daily dressing, oftentimes we put Mepilex AG, this silver pad, on just to get them a few days where we can heal up parts of it, we can heal up the edges, and they don't have any like trauma during those days. And we'll wrap it in Curlex. Sometimes if it's a limb, we'll put Coban on top of it, like the stuff they wrap around dogs so they don't bite their stitches. We use the same thing for toddlers. So, and that kind of keeps it in place, and they're not able to peel it off as well. Vosh is another thing we use. It's like super duper wound cleanser. It helps kind of debride that thick eschar you saw, and it also helps with faces a lot to help get all the protein sludge that gets built up there that can cause scarring to be worse. So we often do Vosh soaks for faces, but really we use Vosh anywhere on the body. It's really good at cleaning and helping debride and clean up wounds once they're a couple days old. So this is a picture of another product we used to use, which is xenograft, which is a pork skin graft. And the company during COVID has gone out of business or not making product anymore. So we're in the midst of switching over to Superthel, but basically this is like a, we have the other, no. So it's a pig skin that we put over top of the burn wound in the operating room. And after it's been cleaned and debrided, and it goes on top of the skin, and then we treat the outside of it with Xeroform or something else, and this stays in place and acts as like a scab kind of. That stays in place and grows out with the skin as the skin heals, and then you see on the areas it's flaking off, then we trim that back and peel it. But it helps tremendously with pain control for bigger burns. So next, fluid resuscitation. So Cindy has done a lot of work on this. She's a great resource. Burns less than 15% TBSA, we don't do much fluid resuscitation. We do maintenance IV fluids. We try to get these kids, if they're not going to the OR right away, which some of them don't, we try to get them eating as soon as possible. So once a kid that's under 15% is eating, you know, at least 75% of a diet, sometimes we'll start weaning their IV fluids. But fluids, protein, calories are very important in healing a burn. So if burns are greater than 15% TBSA, those kids are going to the PICU. And the goal, you can see there at the bottom, is under an hour from the emergency department to the PICU. Those kids will get 1.5 maintenance in the emergency department, and then they do a fluid worksheet in the ICU. And they also have a Foley catheter placed in the ICU, which helps dictate the fluid worksheet. So this is, these are the two kind of protocols for emergency department and PICU for our greater than 15% TBSA. So in the emergency department, you're estimating the TBSA using the hand, 1% hand, but also the NSW app. So somebody should have that on their phone. If they don't, nursing, I mean, it's a free app that anybody can download. So it's great for you guys too, if you want to double check what the providers are doing, especially if you feel like it's not matching up well. And then EMS oftentimes gives like a bolus or gives some giant amount of fluid to burn kids, which we ask them not to do, but Sometimes they do anyways. So you want to document how much that is, make sure that's somewhere in the chart so that once they get to the PICU and they're trying to figure out the fluid worksheet, they know how much they got pre-hospital. And then you're going to start lactated ringers at 1.5 maintenance. They don't require any boluses. And then you want to cover the burn with a clean sheet. Sometimes we'll have you wrap it with cling, and then try to get them to the PICU in 60 minutes. And covering it, remember, obviously in here too is pain control, but covering it, remember, helps a lot with the pain, because once it's covered up and air is not hitting it, the kids feel a lot better. And then it has the PICU attendings number down there, and you can always consult the burn surgeon day or night if there are questions about where the kid should go. Once the kid is in the PICU, accurate weight is very, very important for the fluid resuscitation worksheet. And then also continuing to see, especially if it's a large burn, if the kid is losing weight as they are in the ICU, that's concerning for us, and nutrition or dietary is always involved. Getting their debridement done so that we can get some sort of product on that is going to treat the burn. And then starting the fluid resuscitation worksheet, like I said, putting the Foley catheter in, and then putting in an NG tube. All of our kids over 15% get an NG tube. Oftentimes, if they're 10% and they're on the floor and they have a face burn, we want an NG tube. Any kid that has a URI is probably going to end up with an NG tube. Once in a while, we give them 12 to 24 hours to try to see what they're going to eat. But when kids have a URI, cold or flu or whatever, they don't want to eat anyways. And so we don't want them to fall farther behind, because it's really important for them to get good nutrition with a burn. This, I think, is just a larger version. So ICU care, pain control, that's also in the emergency department. Debridement and dressing application. Oftentimes we'll do ketamine in the ICU for debridement and dressing change. And then the pictures in Cerner are also very, very good at helping us calculate TBSA, which helps kind of guide the care of these kids. So taking pictures during the debridement while the kid's under ketamine and not squirming all over the place. Then you can go back, sit down, look at the pictures, and actually do the NSW app pretty accurately. Getting the fluid resuscitation worksheet started, so that is available on the internet. It's in the ICU. Everyone should know about it. And then getting the NG and the Foley placed and starting enteral feeds, unless there's any reason that the kid is going to go to the OR, within the next 8 hours. But you can always place the NG tube even if you don't start feeds right away. This is what the fluid resuscitation worksheet looks like. It's not important to know exactly, except for that you look at it, it exists, and that you recognize that this is it when you're looking for it, that this is in fact the worksheet you're looking for. So it's based on the old Parkland, somewhat loosely. If you guys remember, I don't know if you learned about that in school, but that's kind of what this is. Urine output is what dictates what the fluids are. So that's why you need the Foley catheter, and you have to do at least hourly urine checks. Anything, kids under 30 kilos have to have D5 LR as their maintenance fluid, in addition to the 1 cc per kilo per hour of the fluid rate. OR 14 is a procedure type OR that we've had in the past. We're on a little bit of a hiatus now because of COVID, but dedicated OR time basically every day except Thursday for procedures, changing dressings in the OR. It's usually only things that we can do within 45 minutes. And it's the first case of the day. So if you hear somebody talking about it, it's just for you to be aware this kid is going to OR 14. That means it's likely going to be at 7:30 in the morning the next day, and then they'll get their burn dressing done. If they're going for grafting, this is not what they're doing. So burns, reasons to have a burn center referral. So we are a burn center. So these are reasons that other places send burns to us, just in case you're wondering, like why are we getting all these transfer of burns? Anything over 10%, full thickness injuries, hands, feet, genitalia, or perineum involved, suspicion of inflicted injury, circumferential injury, so that we can keep track of neurovascular status. They may need an escharotomy or something like that. Other comorbid diseases. So if the kid is has a difficult medical history to begin with and now has a burn, often those kids will come to us. Any social concerns, which kind of goes along with inflicted injury, but sometimes even if a kid is doesn't have a burn big enough to admit under normal circumstances, but say maybe is homeless or family is having instability in terms of housing, sometimes we'll admit those kids at least for a couple days to see how their burn is progressing and make sure they're going to be okay. Electrical injuries sometimes get referred to the burn center, but not if it's within a house. But if they're like a power line or something like that. And inhalation, obviously. These are complications following a burn injury, fever, which we see a lot of times in kids, trying to suss out whether the fever is related to the burn and any eschar or deep thickness areas, or is it related to the kids' runny nose and cold that they had before they got burned or they got since they got in the hospital. Immunosuppression, so we keep track of these kids' labs. Infection is very rare. We rarely start kids on antibiotics with a burn. Often the kids who get antibiotics are those who are in the ICU or on the floor and go back to the ICU and are having like a sepsis type picture. We do sometimes get staph infections. This is a moist area we're keeping moist for a long period of time, or HSV rash, which is what you see over here. A lot of moisture for a long period of time is an area where that kind of stuff grows. And sometimes even taking the dressing off, giving them soap and water bath and giving them a break from moisture for a couple of days will clear that up. Otherwise, the kids will start with a topical antibiotic like Bactroban, Mupirocin, and then we'll see how that goes. Most of them do not require oral antibiotics for that. Dehydration is a big one. It takes a lot of water to heal a burn. So if these kids aren't eating and drinking as much as they're used to, or they're having fevers and their metabolic rate is high because they're trying to heal and they're trying to get over a fever, dehydration is a big one. Wound conversion. So like I was saying, this happens a lot with our toddlers with scald burns. They will get a deeper burn, or their burn will take longer to heal because they're compromised in other ways. Feeding intolerance. So if you have a kid who has an NG feeds and is having massive diarrhea or vomiting, that means they probably have an issue in their GI tract, and this happens with some of our bigger or deeper burns. And those kids have to go back on IV fluids and stop the feeds because their intestines are, because of the inflammatory response through their body, their intestines are not able to process that food, and they can have injuries or perforations in the bowel if we push that on them. So you got to make sure your kid is peeing appropriately, an appropriate amount, stooling appropriately and the appropriate amount, not getting hugely distended in their belly, and not vomiting. Otherwise, we stop the feeds, even though we really, really push for early feeds and high protein and high calories. We do have a burn fever infection order set, just so that you guys are aware, and that can be ordered by residents on the floor or any of the providers. So any temperature of 39, above 39 times 2, so even if they're 1 hour apart. And the workup includes whether they need antibiotics or not, but that's kind of guided by the protocol. They get labs. They usually get a chest x-ray, urinalysis, Oftentimes a PCR for respiratory viruses. During this time, they would get COVID test. And then we have a sepsis pathway that they would go on to if they had the specific vital sign changes. And then oftentimes a hospitalist consult, because we are a surgery service. So oftentimes we need help kind of figuring out what else could we possibly be missing with this kid, and what other kinds of medical management should we be thinking about. This is our sepsis tool that's used on the floor by nursing. It's just important that you be aware of it, that it's there, and that this is something that we use for burn patients. Some pictures here is this is a, I guess if anybody wants to answer, what type of burn would you call this? There's superficial, superficial partial, deep partial, or full thickness.
Superficial.
Go ahead, you can just shout it out.
Superficial.
Yeah, superficial. So this is like the sunburn we were talking about. So for this kid, what would we do? We would give them, what would the TBSA be on this superficial burn? Shout it out.
0.
0, right.
Yes, I love that. Great answer.
Yeah, what would this kid need, a surgery consult or burn consult? Shout it out.
No.
And treatment or follow-up for this kid would be what?
Yep, primary care provider.
Primary care, A+, great job. Okay, this kid, would you admit this kid or send them home? You can shout it out, no wrong answers.
Admit.
Admit, why?
Needs to be like washed and probably cleaned to see if like the burning is done, and like watch for dehydration, all those different things.
Okay, so for this one, based on the size, and I can't see the other side, but I'm going to assume this is circumferential. If this is circumferential, I want to admit this kid for neurovascular checks for at least 12, 24 hours. If the size that you see right here was on this kid and it wasn't superficial, this kind of a burn could go home potentially. Dressing you would choose for this kid, if you're admitting them, I would choose a daily dressing, because if you're going to have to cut it off and do an escharotomy, I would probably do something that can be easily taken off and changed. If you're going to send this kid home because the other side of their arm is not burned, and this is only what you see here, then you could do a Meplex AG. And then if you do a Meplex AG, that's follow up in clinic, in 3 or 4 days. Clinic is Monday, Wednesday, Friday, so that somewhat dictates when you're going to have the kid come back. Okay, so chemical burns are another kind of burn we don't see very often, but we don't ever recommend using a neutralizing agent, mostly because chemical burns are often caused by either something that the parent doesn't know about, or something that has multiple ingredients and you're not quite sure. So for every type of burn, copious amounts of water. No ice. You see parents put all kinds of things on, toothpaste, eggs, all kinds of stuff. Water, and it should be tepid. You don't need ice. You don't need freezing cold water. But running a burn, whether it's chemical or otherwise, underwater for like 3 to 5 minutes, which it's hard to hold a kid underwater for that long, is hugely helpful in stopping the tissue from burning and keeping this to more of a superficial level. Treadmill injuries are another thing we see, special case. This is a treadmill injury of a hand. These injuries are very bad, very deep. Some things you have to think about is tendon involvement, muscle involvement. Do they have a fracture? So these kids should get an x-ray. but these kids, we want to see, the surgery team should see all of these kids, and these kids take a long time to heal. It's surprising, most of them do not get a graft. They heal primarily, and hands are pretty good at healing, but it takes a really, really long time, and we have to make sure they don't have tendons or fractures or anything like that. Electrical burns, I mentioned this earlier. Any kid exposed to a common household, like sticking a knife into a socket, if it's a house in America, most places it's less than 240 volts, so they don't need an EKG, they don't need a bunch of labs, they don't need to be admitted necessarily. Usually this is a discharge home from the ED. Now, if you're talking about a power line outside or something like that, that is a whole different scenario, but just so you can set parents' mind at ease about burns, that electrical shocks or burns that happen inside of a home. We treat the injury, the cutaneous injury, and then they follow up with their primary care. This is about burn surgeon notification. You don't really need to know that, except for that the burn surgeon is notified within a certain amount of time based on the TBSA. We talked about this a little bit, but social work is a great resource, especially in the ER, but also on the floor and in the ICU. If you're like not quite sure and you don't want to be the one who says the dirty word of CPS, you can always get a social work screen. These people, especially the social workers that we work with on our service, are wonderful. They can tell you this is something we see all the time, or this is out of the ordinary. And they will often be the ones to contact CPS or get CAPC involved. Going home from the hospital. So these are things to consider. These are some videos that we have available, and they're available on the Get Well Network. So you guys can have them ordered for your kids, but also I think nursing can order any of the Get Well Network videos, and you should watch these. I can have Cindy send them out. But they're all available on Get Well Network. Preparing for burn clinic, going home from the hospital, staying in the PICU, staying in surgical care, and then burn care in the operating room. These are the ones I was talking about earlier. All right, any questions? We have like 10 seconds.
We do have one question in the chat. I just need to scroll back up to it.
Sure. Sorry.
How do you determine frequency of dressing changes throughout the healing process?
Sorry?
How do you determine frequency of dressing changes throughout the healing process?
Great question. So it totally depends on the depth of the burn, also depends on a lot of things. So if the kid is admitted, it's really like a determination based on the depth, based on whether we think this thing has the potential to heal, or whether they're going to need to go to the OR, where it's located on the body. Is this something that we can change? Is this something that we can use sedation at the bedside? Is this something that this patient tolerates? Was this a traumatic type of burn where there was a big event around it, and does the kid have outside anxiety and stuff about that? Sometimes we'll try to put longer acting dressings on. When the kid is outpatient and we're seeing them in clinic, it has a lot to do with what type of burn, and but mostly it has to do with the parents. If the parents are okay doing a daily dressing and we think it's needed, then that's great. We can have them do a daily dressing. Sometimes we check in with them via telemed. Sometimes we can have those kids come back in 2 weeks. There are some kids that we want to keep a very, very close eye on, either because of the burn or because of the parents. And that could be a host of issues. The kid is one of 7, and we're just afraid, the older kid's going to tear off the dressing. The mom's not going to be able to keep up. Whatever the case may be, they could be, in a social situation where they are lower resourced, or they are homeless, or they are, we just want to keep a closer eye on this kid. Sometimes we'll put those kids in a long acting dressing, but have them follow up every 3 to 5 days so that we can make sure they get there, that we see them, that the kid is doing okay, but we put them in a long acting dressing so that the parent doesn't have to do much at home. So all of those things kind of get weighed in. The child themselves and what they're going through and how they're handling it. Some kids will amaze you. Huge burn, looks like it's painful, and they'll like sit and watch a YouTube video while you do their dressing. Other kids, especially seems to be like 4 to 7 year olds are very, very anxious about dressing changes and recurring. And half your time is spent just talking them through it, getting them to breathe, using child life, all that kind of stuff. The younger they are, usually the better they do. And it depends, some of them will scream bloody murder while you're doing the dressing, and the second you stop, they stop. And some of them will sit there and play with bubbles or a lightsaber or something while you're doing the dressing and not bat an eye. So it depends on the kid, depends on the parents, depends on the burn, I guess, is the short answer, which you didn't get a short answer about.
And then one last question. Can you explain how laser treatments work?
Sure. So laser, we initiate laser with kids whose burn did not heal within 3 weeks usually. And it's usually like a month, or they probably are a month or 2 out from their burn. So the things that are indicated for laser, it's not necessarily aesthetics, but if a kid is having pain with itching or mobility, or has like a very reactive scar, we will often initiate laser for those kids. And there's a couple different types of laser, but like similar to the one we use, I think, is pulse dye. And basically it breaks open little areas of the scar, and then they're able to regenerate under basically like a less stressful situation. Like the body is not trying to heal to survive. So you're punching little holes in the scar, and then using massage and moisture and compression and silicone to try to make that scar kind of soften, and it makes them less itchy. So you're kind of, the body races to heal things so that we don't die from a burn. And then what you're basically doing is going back and breaking some of that scar apart and doing it in more of a slow fashion so that the kid can have greater mobility, less itching, less of like a raised scar. Sometimes it will change the appearance, but we don't necessarily initiate laser treatments because of the appearance. It's usually for a functional reason. Hope that
Okay.
the question.
Thank you so much,
Yeah.
Caitlin. And that was fantastic. That was great.